Hey, it's 9:02, so maybe we'll get started, and I'm sure a few more people will trickle in. So thank you all so much for joining us today. We've had a lot of interest in people being able to hear about some of the learnings that we had on a recent trip that some of our team members did to the UK to learn more about social prescribing. So we thought we would host a webinar, and so open it up to multiple people to come and hear about our trip and what we were able to learn. So my name is Beth Mansell. I'm with Healthy Aging Alberta, and I'm our provincial social prescribing project manager. To start today with land acknowledgement. I'm joining today from Edmonton in Treaty 6 territory, and I would like to thank the diverse Indigenous peoples whose ancestors' footsteps have marked this territory for centuries, such as the Nehiyaw, Dene, Anishinaabe, Saulteaux, Nakota Iska, and Nakota Sioux, and the Nitis-Tanapi, and the Blackfoot peoples. Also acknowledge this as the Métis homeland and one of the largest communities of Inuit as well. We're grateful for the traditional knowledge keepers and elders who are still with us today and those who have gone before us. I know Zoom webinars are not a new thing for everyone anymore, but just some housekeeping items on this slide. I would ask everyone to please mute themselves throughout the presentation. We will have a question and answer period at the end. And you can either put your questions in the chat, and if we have time, we might be able to do some more interactive questions as well. And if we do that, please ask that you raise your hand, and we'll kind of go through the different hands and make sure that everyone has an opportunity to ask their question. Presentation is also being recorded and will be shared in an email after the event, as well as through Core Alberta. So I realize there's quite a few new faces here as well from our health system colleagues. I'm actually going to start with a bit of a poll before we get into the meat and potatoes of the presentation. So I'm just going to launch that here. Hopefully this shows up for everyone. We're just hoping to get a sense of who is here in the room with us today, and then what your interest is in social prescribing. So I'll give everyone a few minutes just to answer this poll. Wait, maybe 10 more seconds here for just the last few people to respond. Awesome. End it and share results. So it looks like we've got a good balance of people here, some from the health system and a lot of others from community organizations, and a range of interest in social prescribing. So either people are currently implementing social prescribing in Alberta, few people are doing similar work to social prescribing, but maybe it's not called social prescribing right now. Some folks are joining from somewhere else in the country and implementing social prescribing, and then there's a large chunk of people that just want to learn more about social prescribing. So that's great. Hopefully we're able to address everyone's interest during this presentation here. I wanted to start just with a quick context of Healthy Aging Alberta and a very, very brief overview of our work. Oops. It says I'm still sharing the poll. Stop. There we go. Okay, let's hope that doesn't pop up again. So Healthy Aging Alberta, it's a community-based initiative. And our main goal is to coordinate the community-based senior serving sector here in Alberta. And so our approach over the past few years is really focused on creating a network of organizations that can advocate for healthy aging on a provincial level, share knowledge, and create functional relationships with one another. We're also working to create relationships and collaborate with our allies in health, housing, and other sectors, all while keeping seniors and older adults at the center of our work. Because really, at the heart of Healthy Aging Alberta's purpose are the older adults across Alberta, and we want to make sure that older adults can age in the right way for them. So, with that kind of purpose and our objective in supporting older adults across Alberta and the community-based organizations that serve them, social prescribing was a really good fit for Healthy Aging Alberta to take on. And so we're currently supporting the implementation of 10 social prescribing programs across Alberta. And so those are the communities that we've been supporting: Calgary, Edmonton, Lethbridge, were our phase one projects that started in December of 2022. And then our 7 new communities: Sylvan Lake, Innisfail, Jasper, Whitecourt, Vulcan, Wheatland County, and Red Deer County. We started there in October 2023. But the impetus for social prescribing has really been emerging in the community-based senior serving sector for probably the past 4 to 5 years now. There's been lots of conversations and talks about what this type of work could look like for older adults. A lot of our learnings were from readings from what was happening in the UK. And we've kind of taken the approach here of connecting with the healthcare system, employing a navigator, link worker type of role in a community-based organization, and then building out those referral pathways between health and community services. So now we'll dig into the actual learning piece of the webinar. And so for those of you that don't know, there's a national organization called the Canadian Institute for Social Prescribing. They're funded and kind of facilitated by the Canadian Red Cross. And so they organized a learning trip to the UK. It was in November of last year. There were 28 representatives from across Canada that were able to attend. So representatives from the Institute as well as the Canadian Red Cross. There's academic researchers, some folks from KPMG, and then other organizations that are implementing social prescribing initiatives in their provinces. So there was folks from British Columbia, Saskatchewan, Quebec, Ontario, and Nova Scotia, as well as our team from Healthy Aging Alberta. And so there were 4 of us that were really fortunate to attend this learning trip. So they're all here today. So Karen McDonald is our provincial director. Miriam El-Gawaji is our manager for the team of Healthy Aging Alberta. Rebecca Aspden is our community development team lead, and then myself as well. And so the purpose of the trip was really to build our knowledge of the history and models of social prescribing in the UK, to learn about what social prescribing was looking like in various settings, to gain insight into the barriers and facilitators of social prescribing implementation, research, and what that's looked like for scaling across the country. And then also, because the 28 of us that were attending don't really get much of a chance to connect in person, it was also a really great opportunity to deepen our collaboration across Canada as well. And so our 5-day trip included site visits, meetings, and then roundtable discussions with the Bromley by Bow Centre. It was really like the birthplace of social prescribing in the UK. Meetings and presentations from the National Health Service, so NHS England, the National Academy for Social Prescribing, UK-based social prescribing researchers, and then a trip to a community called Froome, and presentations and meetings with their Health Connection team there. So we've themed our learnings into these 6 areas that we thought would be interesting to folks here in Alberta and others that are joining us. And so first we'll talk about what scale and spread look like in the UK. We'll then talk a little bit more about the funding and the model structure that has emerged throughout the country, what their link worker structure and support looks like, how they've incorporated asset-based community development into the social prescribing models, a little bit about evaluation and evidence building, and then also as well some education and awareness. And we want to preface our presentation by saying we're by no means experts in social prescribing in the UK. We're just taking information that was given to us over the course of the 5 days and relaying that and kind of bringing out those themes and things that we found important. But if there are any questions that we don't have the answer to, we can connect with some of the colleagues that we met in the UK and try and figure out that additional information for you. I want to start with scale and spread. So in the UK, as I was saying, Bromley by Bow and some other community-based organizations, they've been doing social prescribing work for probably close to 20 years. And so really developed from a very much a grassroots perspective in a few communities across the UK. And then what happened was policymakers and government kind of got wind of some of this work that was happening in these smaller communities. And then scale and spread happened really rapidly from a very much a top-down NHS and government approach. And it was really coming from a place of austerity. The UK was noticing that their health outcomes were drastically kind of decreasing in certain areas, and government funds for kind of those more intervention approaches were really limited. And so it was seen as kind of a quick win and something that was relatively kind of cheap and affordable to implement across the country. And so it really happened from 4 years to really move from an idea of like, oh, we could implement this link worker type of role and the social prescribing approach across the country. And it happened like that. And so they went from having a few link workers in these kind of grassroots organizations to over 3,000 link workers funded throughout the country as well. I think what we really learned when we were there was that the social prescribing initiatives that saw the best service delivery were those ones where the organizational values were really strong. And expansion to areas where these values were not as strong maybe indicated to us that the expansion of social prescribing needs to be more slow and intentional. And when I talk about organizational values, I'm referring to things like that community and that organization that's kind of leading the social prescribing model in the community, having really good connection to the community assets, making sure that the workers in those organizations that are part of the model have a good understanding of that link worker role and understand the value of that role amongst their clinical staff. As well, it was really important to have good trust and relationship between the link worker and the clinical staff. And just making sure that people were really kind of champions for the work, and they really kind of embedded those values in their practice and things that they were doing. One of the other key learnings from this was that the implementation of social prescribing is different everywhere, and that flexibility was really important for meeting the specific community needs as well. So the NHS workforce plan now includes a target to recruit 9,000 link workers by 2036. So in about 10 years' time, there'll be double the amount of link workers that there are now throughout the UK. So a little bit more about the funding and the model structure in the UK. So I think a good thing for us in Alberta was that the UK health system is very, very similar to what we have here in Alberta compared to some of the other provinces that were represented on the trip. So the NHS, obviously a singular health authority, similar to AHS, but on a much larger scale, obviously. And then England specifically implemented a primary care network structure about 5 years ago. So very similar to our PCN structure as well. Cover a patient population of about 30 to 50,000. And these PCNs were able to receive funding for at least one full-time link worker role through what they call the Additional Roles Reimbursement Scheme. And so the PCNs in the UK have the ability to apply for these additional roles. I think there's a list of about 15. And depending on the role, there is a different percentage of reimbursement that they would get for the role. But the social prescribing link worker, they were offered 100% reimbursement. So it was obviously an incentive to apply to have that type of role in their primary care network. And so in some cases, the PCN recruited the link workers directly. They worked out of that clinical space. And in other cases, the PCN was able to contract a voluntary sector organization to employ the link worker. And so the people that we spoke to estimated that about 70% of link workers throughout the country were actually employed by a voluntary sector organization. So the PCN had set up a contract with that organization, and that link worker was employed by a charitable organization or by a community-based organization. The actual salary for the link worker did kind of depend on where you were working. And so it did seem like the salaries were a little bit higher if you were employed by a PCN versus a community organization. And so community organizations in the UK are trying to kind of fight back against some of that and make sure that if they are employing those roles, that they're fully reimbursed for the true cost of the role. And that was it for funding. It was just that link worker role that was funded by the NHS. There was no real investment in the types of programs and services that a link worker would be able to connect into. So I know there was quite a few people that are just interested in learning more about social prescribing. So I'll give a very, very brief overview of what that might look like. So you go and visit your doctor, and your doctor realizes that there's some unmet non-medical needs, like maybe you need some support with meal delivery or assisted transportation, or you're just looking to get involved in a social club, a coffee club. So that doctor makes a referral to the link worker. That link worker then meets with the patient or the client and connects them to those services that are provided in community. So they may be connecting you with Meals on Wheels, or they're helping you to fill out an application for subsidized transportation. Or they're saying that you should attend your local senior center because they know there's a really great social group that's happening there. So the funding for all of those types of programs and services that the link worker would be able to connect a person to, there was no funding following those referrals and those services. So again, that's something that the voluntary sector in the UK is really pushing for now, because those things don't just happen by accident. They need to be supported by meaningful investment and engagement from various different sectors. So one of the things that's kind of emerged in the UK as in response to that is this concept of shared investment funds. And so these shared investment funds are open to public, private, and philanthropic investment in specific communities. And that funding is coming from a wide range of partners. So it could be national funders, it could be the local council or the local authority, businesses, etc. And the decision makers are kind of made up from a diverse range of people as well, including perhaps the link worker, healthcare providers, voluntary organizations, and then just local residents and citizens that work together to identify what the greatest needs are in their area and how to kind of put that funding to where there might be gaps. And so the goal is to have those programs and services in community be more strategically funded and more stable so that people can access those services when they need. So this is something that's only just starting in the UK, this concept of shared investment funds, but it seems to be really, really well received, and communities are seeing big benefit with that. And some of the other kind of differences and similarities in some ways, the role of the local authorities in the UK is a lot different than it is here in Canada. And so there is obviously a lot of complexity behind that as well. But in the UK, the local authorities or the local council, so like the city or the town council, they're responsible for providing social housing and providing social care. And so there's some of those differences that we noticed as well. So, for example, like the role of social work in the UK really sits with that local authority in terms of what those social workers are able to do. Whereas I think we know in Canada, it looks a little bit different. And a lot of the time we have social workers that are kind of embedded within community organizations. And so one of our challenges over the past few years when we've been implementing social prescribing is kind of teasing that out and figuring out where the role of the link worker ends and where the role of the social worker might begin in community. And then one of the other differences that we noted was just the scale of national partnerships with organizations like Historic England and the Arts Council England and Sport England and big organizations like that. And they've really partnered with the National Academy for Social Prescribing to develop specific evidence briefs around social prescribing and those specific activities. And then they've been able to target funding for social prescribing to those types of services. So, for example, with Historic England and visiting historical sites, they've been able to maybe provide, subsidies and things for those link workers across the country to make connections to historic locations and museums and those types of things, with perhaps having some subsidized funding available for those types of activities. So just looking at those partnerships on a very national level was really interesting. So the next piece that we wanted to talk about was more around that link worker structure. And so a link worker is kind of a non-professional role. There's no specific educational requirements that someone requires to be a link worker. And what we found was that their engagement was quite structured in most communities. So after a referral was made to the link worker, whether that referral was coming from a healthcare provider or maybe in some cases it was a self-referral, that link worker had 6 one-hour sessions with a client. One full-time link worker, their caseload annually is between 200 and 250 clients. The one thing that we did find quite interesting, though, was that the places that we visited, the link workers were quite intentional about structuring their weeks to really include community engagement. So they spent 3.5 days a week on that one-on-one client work, so those one-hour sessions with the clients. 1 day of community engagement and attendance at community programs. So that was going out into the community, attending coffee clubs, going to maybe a fitness class, getting to know the people that were at those programs, so that when they were working with a client one-on-one, and that client was maybe indicating, oh, I would really like to go to the local senior center, but I don't know anyone there and I'm kind of scared to do that. The link worker would be able to say, well, I've already been to that coffee club and there's a great group of people there. I know Jane. Jane would be a great person for you to connect with when you first go. So if they didn't intentionally make that time to go out and build those relationships in different community programs, they wouldn't be able to refer their clients as well. And then they spent half a day a week connecting with different healthcare teams. So going out, talking to providers, making that intentional connection between health and their role and those services as well. So for link workers that were either employed by the PCN or in a voluntary organization, for many of them, their support included access to external clinical supervision monthly. There's also a national link worker advisory group that's kind of formed and is making sure that those link workers have training and support and different resources that they can access no matter where they are in the country. And then the thing that we learned at that national level was there's a big push right now for continued investment in that infrastructure and support for the link worker role. So making sure that they have good training resources and good training materials, access to things like that supervision. And they are starting to kind of introduce some more specialist link worker roles. So for example, they've started to kind of introduce things like a mental health link worker or a housing link worker. And so if they're working in kind of a larger setting where maybe there's 4 or 5 link workers, there's kind of that generalist person. And then if people have the more specific needs, they're referring on to those specialized roles. Even the link workers that are employed by voluntary sector organizations, they still work in kind of primary care practices quite regularly. So they're still connected really well to those teams. And I think one of our key takeaways was that there's pros and cons to wherever the link worker is situated, and that influences the strengths of their relationships. So it's not about, oh, the link worker is employed by the health system and they work at a PCN, or, oh, the link worker is employed by a voluntary organization. It's really about the values that underpin where they are. I think there was some really great examples of where the link worker did work out of the PCN office and had really great connections with the community. And then obviously there was some examples where that was the case and the link worker didn't have good connections with the community. So it's really like, I think it showed to us it's the values that those organizations have that really influence the strength of the relationships. And there's going to be pros and cons to both of those situations as well. Pass it over to my colleague Rebecca now to talk a little bit more about the asset-based community development incorporation into the social prescribing work there.
Perfect. Thanks, Beth. I'm so excited to be able to share this work with everybody, as it really lights me up. This is my jam, to be sure. And I'm hoping you're finding some gems so far, and we do encourage you to share any ideas that are sparking or any excitement in the chat as we go through. So as you heard Beth mention, the most successful models that we saw were the ones that allowed time for link workers to be part of the community. The link worker the role includes collaborating with local partners to support community groups to be accessible and sustainable, and to help people start new groups. This integration of community development and navigation was a massive takeaway for us. These communities really understood the nuances of asset-based community development, and it was foundational to their success. And so when you see statements like these quotes that we gathered from the trip, you can see how social prescribing goes beyond traditional navigation services and even beyond building strong individual relationships, and evolves into building whole and connected communities that in turn support its citizens. Often when we present on social prescribing, we hear we have been doing this for years, and certainly many have been doing pieces of this work, but it's this knitting together of formal supports and community, which is distinct from community services, which has really helped us articulate the whole picture. So there's a duality here, and we all know community supports are essential to well-being, especially when one is navigating crisis. And the link workers work in this space every day. But they also have the opportunity to draw out the gifts and the passions that is unique to each person and enable them to share it in a way that makes them feel valued. Now, in times of distress, this may seem secondary, but thinking of our own tribulation, certainly knowing that you're cared for and have something to contribute can make things more bearable. So when link workers have time to not only draw on, but increase the strengths and capacities of local communities, this is where some real magic can happen. Working together with local partners such as FCSS, senior centers, legions, but also that person who is always baking for everyone, or that local artist who loves sharing their skills, can collectively ensure that local organizations and grassroots groups are sustainable and that community assets are nurtured by bringing people together with similar interests, making them aware of small grants, providing support to set up new community groups and services where gaps are identified, and finding creative community solutions to local issues. This creates a space for people to stay strong, safe, and connected as contributing citizens. And when we start leveraging community, and not just community supports, we can find practical, preventative, non-service solutions that have the potential to ease some of the burden of stress systems while building more welcoming, inclusive, and supportive community. And so the picture here is actually Bromley by Bow, which was one of the organizations that we had the pleasure of visiting. It's an amazing community. It's a borough in London, which is often credited as being the birthplace of social prescribing. They're extremely diverse population and not at all affluent. So their model, sorry, Beth, I should have asked you to progress the slide. I did it on my screen. Thank you. So this model is steeped in community and health integration. And in fact, the health center sits in the middle of the community center, surrounded by social enterprises, meeting spaces, and art studios. Their goal is to work towards a health creation model, informed by an understanding that health and well-being is created within communities through unlocking and harnessing the latent resources that are community. They believe ultimately it is people rather than organizations that most inform the direction of their lives and their outcomes. These outcomes are lived out in the community context rather than within the walls of the organization. The core outcomes that people in Bromley by Bow value most in their lives are feeling good in myself, connection to others, giving and getting back. And so the programs and models reflect these. Sorry, this is the moment my dog's going to bark. And as Beth mentioned, the values really influence the strengths of relationships in social prescribing. And Bromley by Bow's active values are to be compassionate, be a friend, have fun, and my personal favorite, assume it's possible. So in the spirit of Valentine's Day, I would like to pronounce my huge crush on this community. And I'm sure if you take time to do a Google dive, you will quickly develop one as well. Next slide, please, Beth. All right, so continuing on that theme of ardor, another love of mine is Frome, the town who cured loneliness. Although quite different than Bromley in demographic makeup, they both marry community and health in a very intentional way. So Frome is part of a wider Frome model of enhanced primary care, and it works in 3 steps. So the first one is mapping community asset. And from befriending services to peer support groups, credit unions, exercise classes, and things like that, the project maps over 500 services and activities in the local community. And crucially, it also identifies gaps. And so step 2 is helping local people fill those gaps. So to build social capital, the project works with local people, community groups, and partners to identify where new services and activities would be of an added value. It then helps people create those assets in a sustainable way through support with aspects like recruitment, legalities, and funding. And lastly, step 3 is signposting. So they do something really cool here where they train volunteers to be community connectors, and they simply signpost family, friends, and neighbors to the community services that could be helpful. Of course, they have a really vibrant social prescribing project where patients meet health connectors to discuss their health, set goals, and connect with community services and activities, where patients can self-refer, but also be referred by their GP. And they also have talking cafes where people who feel isolated or wish to meet people and learn about community services and activities can pop into the local cafe and chat with one another and a community connector. It's interesting that they say that supporting people with unmet needs to access supports, formal supports in the community is only about 30% of the time. The 70% of the time is often about connecting them to themselves, connecting to others, their families, neighbors, pets, and a wider sense of community. And yes, it really is this picturesque. You actually do start to believe Hallmark movies could be true when you are standing in Frome. And so lastly, next slide, Beth. I just quickly wanted to touch on the Common Outcomes Framework for Social Prescribing produced by the National Health Service England, and how it identifies not only the impact on social prescribing on the person, but also on the community and the healthcare system. So the points above or on the slide are taken from the framework, and you will see that community involvement, investment, and development are core values that run through every statement. I won't belabor these as we will be sharing these slides for those who want to take a closer look, but I think they are also a nice segue into our next theme, which is evaluation, evidence building. And so I'll hand it back up to Beth.
So thank you so much, Rebecca. So we wanted to touch on some of the evaluation and evidence building pieces that we learned, because it's always everyone's number one question is like, well, what are the outcomes and what are they seeing? And so there's been a lot of research studies and evaluation that's been done over the past few years in the UK. So these are some of the common outcomes that get reported. They're definitely not all of them, but in general, they're seeing a 12% reduction in GP appointments, so in primary care appointments, 15 to 20% reduction in secondary care costs, return on investment of £3.50 for every £1 invested, and measurable improvements in a person's well-being, physical and mental health as well. I think some of our most important learnings around evaluation and evidence building, though, there was one quote that the director of evidence from the National Academy shared, and it's complicated and everything matters. And so I think that was really, really reassuring for us, because our evaluation framework has been a challenging thing to kind of develop and make sure that we're measuring the right things, because it's a very, very complex intervention when you think about social prescribing. We're looking at the referral pathway, we're looking at the interventions that people are being connected to, And we're trying to make sure that this all fits into kind of more of a medical model of research evidence, because that's where the money is, and that's where we know that future investment will come from. So one of the researchers that we met with had a really good quote as well, that social prescribing isn't necessarily a health intervention, it's a community development intervention. And so changing some of this language is important to shift some of this work into community and take some of that control away from health, because it's very difficult to fit this type of community intervention into that medical model of research evidence. And so even in the UK, where they've got like hundreds of people doing research and evaluation on social prescribing now, they're having a very tough time standardizing the quality and range of social prescribing evaluation and the interventions. Some of the other comments that were made to us was that focusing on the implementation piece of evaluation is just as important as the intervention and the outcomes on the clients themselves. So what is working well for communities when they're implementing social prescribing, and how can that be shared with others? Thinking about the pathways that are being created between health and community, what are the types of outcome measures that are needed to look at that as well, not just the activities themselves. And then looking at it from more of a population health level, one of the things that was really interesting for me was thinking about that kind of basket of services that are available in a community, and looking at how effective we are at bringing people to those basket of services at a population health level. One of the other interesting things that came up when we were there and chatting with some folks from the NHS was that when they started looking at some of the demographic data early on in social prescribing, they were seeing that the majority of referrals were actually for like middle-aged white women. And so that was who doctors were referring to the link worker. And that obviously was missing a huge part of the demographic, and from people that could really benefit from connecting with a link worker. And so this was just a good reminder for us that we need to be collecting, good demographic data to make sure that we are reaching those people that would really benefit from connecting with a link worker and connecting to those community supports and services. And then the last thing that we wanted to touch on was just the level of education and awareness that's happened around social prescribing in the UK. So a lot of this has been done through the National Academy for Social Prescribing. The National Academy was set up as like an arm's length government charity. I think they're considered, they have a board of trustees, but they were given an initial investment, and they were kind of set up to really oversee the development of social prescribing across the UK. And so one of the things that they've done is develop like a champion scheme and champion programs to really build awareness for social prescribing across the health system. And so identified like healthcare provider champions that really understand the role of the link worker and are able to kind of connect on a peer-to-peer level with their colleagues. They've also developed like link worker champion schemes where there's more experienced link workers that kind of advocate for the role and work on that peer-to-peer level with other newer link workers as well. Also really focused on public policy connections and making sure that social prescribing is embedded in a lot of the policy documents at a national level. You'll see if you look at their website, they've got quotes on how important social prescribing is from some of their key ministers. And I think they even had like now King Charles speak at their most recent conference that they had on social prescribing. So really making sure it's building into that kind of public discourse. And then the last piece is just building that public awareness, because they have social prescribing spread across the whole country now, and almost everyone across the UK has access to a link worker. They've been able to really build that public awareness of social prescribing and its impact in the community as well. I don't think we're at that level here in Alberta just yet. I think it would be a little worrying if everyone in the province was aware of social prescribing and we didn't have the capacity to actually connect them with a link worker. but they've seen a really big increase in people's understanding and awareness of social prescribing through some public campaigns that they've done over the past few years there. So what's next? So as we mentioned at the start, here at Healthy Aging Alberta, we've been supporting 10 different communities across the province to implement social prescribing. And so we've been focusing there on building those intentional connections between healthcare partners and those community-based organizations in the community. And we're really looking at making sure that we're building a good foundation for this type of approach to social prescribing and this type of model. But we want to continue building those connections and really focusing on that intentional scale and spread. But as we all know, I think money and future sustainable investment is required for that to happen. And so that the team at Healthy Aging Alberta has been working with other communities as well to kind of lay some of that groundwork for when future investment does become available. And so in terms of everyone that's on this call today, I think what's next is to continue talking about social prescribing. If you think this is kind of a sustainable solution to connecting people to different resources and community and getting them supported. I think we just are hoping that people will continue talking about this and kind of advocating for this approach at a variety of different levels, whether that's within the healthcare teams that you might work in, whether that's with local levels of government as well. We want to make sure that it's kind of a community-driven kind of approach as well. And that people have, the opportunity to access these types of programs and support. So I'm going to pass it over very briefly. We're going to do some Q&A, but before we get there, I thought we could hear from both Karen McDonald and Miriam El-Gawaji, who are also on the trip with us, just in case we missed anything or they wanted to share any additional reflections.
Thanks, Beth. I just really appreciate everybody being here with us today. Obviously, there's a lot of enthusiasm and excitement around social prescribing in Alberta, which is really encouraging. I think the two key takeaways I wanted to share and just a couple notes about Beth and Rebecca's presentation. I think the thing for me that really struck me as we were sitting in these presentations in the UK is that we're on the right track here in Alberta. There's really great work happening here. And when we heard from our colleagues around the things that are working well in the UK, they often dovetailed with the direction we're headed here. And so I just really wanted to share my excitement and that sensation of, okay, you know what, we're often concerned that, we feel this pressure and anxiety around the things that aren't working. And so it was really exciting and encouraging to hear that many of their key learnings are reflected in the direction that we're going here in Alberta around that co-creation approach with government and community and health, our commitment to those community development principles. It was really encouraging. So I wanted to share that reflection. The second piece was that the challenges that we are experiencing, for example, the complexity that the people that we serve are experiencing in their lives right now, the pressures that exist in systems, both in our health system and also our community system, they're universal. The exact same things are happening for our colleagues and for community members in the UK. And so we as professionals are equally trying to figure out the best path forward to support our community members and our colleagues in systems that are feeling those pressures. And so we're not alone in those challenges. And so I found that also, not to say that it's not still a challenge, but it is reassuring to hear that that within social prescribing, those challenges exist in other systems. And I just wanted to share two key things just to add to the presentation earlier. That when social prescribing was emerging in the UK, there was a couple of key policy documents that were really seminal in creating the foundation for social prescribing to emerge as a movement within their systems there. There was one on primary care and another one on loneliness that really helped to cement social prescribing as a potential policy solution within government and within systems. So, when we're thinking about how we create kind of that shared mental model for changes in approach to systems, I wanted to just mention that our colleagues mentioned those two key policy documents helped to create that momentum. and shared understanding around the role of social prescribing nationally. And then the second thing is that there is always that instinct to maybe use the term social prescribing in convenient ways. And so I think that exists right across the board, right? It becomes a bit of a catch-all phrase. And so I think, that happens in all systems. And so just to reinforce the idea that social prescribing is really about the role of that link worker in that supported navigation and that relational approach to supporting that individual in achieving their goals around their own health and well-being, and creating the systems that support that. And that it does not include necessarily those supports and services that the link worker is helping that individual access. And so when we're building out a social prescribing network and system, we need to remember to invest in those additional supports. But when we refer to social prescribing, it doesn't include all those extra services and supports that people need access to. So I think that that's a key takeaway as well, is that sometimes we want to bundle those things together, and just remembering that that requires additional work to build that out. So that was just another key reflection for me. Miriam, did you want to add your thoughts?
Sorry, just muting there. Thanks everyone for being here. And I don't have a lot to add. I think just one of the things that really stood out for me was just the complications around the valuation, and trying to establish something that is coordinated across obviously a country, but as we're trying to do here in Alberta, across Alberta, and the national efforts that are happening. So that is definitely taking time. It's taking time in the UK, and I think it just kind of gives us a little bit of solace when we are all trying to bring together our data and our outcomes, that it is a process that is lengthy, and it takes a lot of work, and it takes a lot of collaboration. And it's really exciting to see that people are very open to that collaboration at this point, and that they understand the importance of sort of working together to ensure that the system can shift, and that there is enough of a critical mass that allows for that system change to happen. And the types of relationships that are being developed with funders now are also a really important piece, like how people are working a little bit differently. Obviously, there are still funding models that are not necessarily conducive to the work. However, there are funders that are really being very intentional about being creative and being supportive of not only implementing programming and delivering services, but how do we coordinate and how do we build systems that work well. So from that perspective, I'm just encouraged by all the people that are willing to participate and add their voice to doing the systems level work while doing the frontline work. It's hard, and it takes a lot of effort, and I commend everyone that is involved in that work. But yeah, thank you. I will stop talking so that we can have time for our Q&A.
So there's a few questions that came in the chat. Miriam did answer some, but I'm going to say them verbally again as well, just for folks that might not have caught the original question, or if you're tuning in afterwards here on the recording. One of the questions was, how do you add community program or service to a link worker list of resources? And do you mind answering that again verbally in the conversation here?
Oh, sure. I just put an answer there. I was just saying that it really depends on the community. So different communities might have different sort of mechanisms by which they are coordinating services. Froome, for example, again, as Beth talked about, had a system by where folks could add services, and the community health center was being proactive about adding services into there. Here in Alberta, obviously we have 211, but there are also other mechanisms that are more local. But the importance of like actually building relationships with those geographically relevant resources was really emphasized when we were in the UK, in terms of having that link worker having time to create relationships with some of those local resources, to even understand the program well, or the services well, and be able to do that warm handoff and that connection to those resources, because it is about a supported approach and not just a referral.
Wonderful. The next question was, do residents pay out of pocket for the basket of services, or are the options publicly funded? and this was in direction to the UK basket of services.
Yeah, and my response to that was, yeah, most of them were publicly funded, but there were long wait lists depending on what it was. So there was a recognition that although, you know, there was funding for all these link workers, there needed to be equivalent funding to ensure that those services were equitably available to people. So that is, you know, it's the same thing that we're seeing here in Alberta, and it's an important message, again, to share with government and with funders in terms of like those things. It's a continuum. Social prescribing is about navigation and supported navigation and that relational approach. But the services still need to be funded in terms of those non-medical supports that people need to be able to age well.
Yeah, maybe just to add to that too, I think one of the things that really struck me is that the model of social prescribing is really influenced by when and how the social prescribing model emerges. So in the UK, their model, as Beth mentioned in that one slide, has really focused on people's overall well-being. So people have access to things like the Nature Trust, where access to nature is really important, access to art and history, and people's well-being goals are really considered. In Alberta, our social prescribing model for older adults specifically has emerged during the pandemic. It was really about meeting people's basic needs, ensuring that we're, you know, taking some pressure off of a very stretched health system. Our referral pathways really reflect that, right? We're not referring people into museums at this moment in time, primarily. That's not our focus, because that's just when and how our model has emerged. And so we're excited by the potential to think more broadly about well-being as we sort of emerge through this post-pandemic phase, and develop new partnerships with new organizations to be part of that network, right? So I just want to flag that as something that we also noted.
Okay, the next question. What are the steps to creating a link worker position? What if there isn't a person or position already available in the community who funds the role?
I can answer this one. So in the 10 communities that we've been working with, Healthy Aging Alberta has been funding those roles through an anonymous trust that's been interested in kind of developing social prescribing across Canada. But in a few of those communities, there are other funders as well. So in the larger cities, the government of Alberta has also been providing some funding for that link worker role. And in some of the smaller communities as well, FCSS has been contributing to a portion of the role as well. So when it comes to kind of creating a link worker position, right now, I think new communities that are interested in this type of work are applying to a variety of different funding sources to try and get support for that type of role. In the future, I would hope that we have more of a consistent approach to that, where there is some kind of provincial source of funding that is available for supporting that type of position.
Perfect.
Can
Can
I add to that? Sorry, Stephanie?
Mhm.
Yeah, sorry, I just, there are some communities in Alberta trying to prepare this for this, knowing that funds aren't always regular or coming through. And so they're coming together as a community and having some really hard but courageous conversations around duplication of services. And if somebody could take a piece off that another organization's plate, they could, if it was important to the community, free up resources for a link worker. And we do have, that's worked really hard on building a curriculum for link worker training that is available too through Healthy Aging Alberta. So just in case you're looking at scenarios where funding might not be imminent.
Thank you. Okay, we do have one that's a comment in the chat, just to make folks aware that there is an international social prescribing conference in Canada this year. It's going to be hosted in Toronto from September 26th to 27th, and submissions are open till February 26th now. They just extended the deadline. So there is a link in the chat, but I know Healthy Aging Alberta, we've also shared it on our platforms on Core Alberta and LinkedIn. So if you're interested, you could follow up with that. The next question. Was there any talk about the term prescribing that has a historic notion that suggests being told to do by physician?
I can answer.
Sure.
Okay. Yes. There is, and there is a push to sort of move away from medical terminology because it can, for some folks, create some resistance. And so in the UK, they often talk about connector schemes rather than social prescribing. But the other piece to that is, right or wrong, sometimes when a doctor tells you to do things, it adds validity. So people sometimes are more willing to follow through on it because somebody that they trust already is telling them that it would be a benefit for them. And I will let my colleagues add to that as they see fit.
Okay. The next one, in the communities you are working with in Alberta, are the link workers hired by the PCNs or municipalities?
It's a great question. So right now, the 10 communities that we're working with, all of those link workers are employed by what we would call a community-based organization, a community-based senior serving organization. So in the larger cities, social service agencies like Sage Seniors Association and Jewish Family Services. And then in some of the smaller communities, they are embedded within the FCSS office, so technically the municipality.
Thank you, Beth.
Sorry,
There
I'm
is
going to jump in again. I'm sorry. I just wanted to say that it is, when you're trying to build a link worker program, it is really essential to look at what red tape or barriers may be existing in the community or in the organization you're going to place them in. So if they don't have the ability to travel out and visit and meet folks where they're at, that might not be the best place for them to sit. So the less risk, red tape and barriers, the more free they can be to do the work that best benefits the person.
Thank you. There's a request that you share your emails again. Since the get in touch function on the Core Alberta site's not working. Laura, thanks for bringing that to my attention. I'm the back end of Core, so I'll look into why that's maybe not working, that your emails aren't coming through. But yes, Beth will put her email back on the screen here so you can send us a message.
Rebecca already put them in the chat.
Oh, yes, Rebecca put them in the chat. Thank you. And you can always, if for some reason you're coming through Core and the getting in touch doesn't work, you can also always email info@healthyagingalberta.ca, and that will get a hold of any of us through this platform.
Steph, we're right at 9:59, and so I just wanted to, I know there's one or two more questions, but we can try and answer those by email. And I wanted to say, I know this presentation didn't focus a lot on our work and the social prescribing work that is happening right now in Alberta. We have done a few previous webinars on that, and there's a lot of information on our website about the work that we're doing. And so in the email that we send out, we'll include some links to some of that information as well, if you're interested in learning more. And always happy to have conversations with folks that are interested in learning more about the social prescribing work that we're doing. So please don't hesitate to reach out if you have any other questions as well. But really appreciate everyone's participation today, and hopefully everyone learned a lot. And yeah, maybe in a few years' time, we'll have hundreds of link workers here in Alberta as well, like they have in the UK now. Thank you, everyone.
Thanks,
for being here,
everyone.
everybody.
Thank you. Take care. Have a great day.
Everyone.
Shall we stop recording? I don't know who has control of that.